Awesome. So we have a lot of varied responses, which is awesome to see. The second question that we want to ask you all, Alina, is where is your organization in the process of integration? Is this something that you guys are all just learning or exploring? Are you beginning to implement? Are you already fully implemented? Or is there ongoing quality improvement? So advanced, not started, beginning. So again, it's very varied, which is awesome. Thank you all for participating in that. We are going to have a couple of activities throughout the training too. So this is the first activity, and our question to you is, what is integrated behavioral health? If you can respond in the chat as well. Holistic view, yes. Providing whole person care to patients, every aspect of healthcare. That is not limited to one treatment or theory. So I'm seeing a lot of whole person care, which is great. I'm gonna go ahead and pass it on to Alina from here, who is gonna move on to the next part of it, which is addressing what integrated healthcare is.
Thank you, Victoria. So I think you guys are doing such a wonderful job. And honestly, if you want to sum up what integrated care is in one word, it really is that holistic care for our patients, right? So let's look at what the actual definition of integrated behavioral health is. So according to the Agency for Healthcare Research and Quality, integrated behavioral health is the care that results from a practice team of primary care and behavioral health clinicians working together with patients and families using a systemic and cost-effective approach to provide patient-centered care of a defined population. The team addresses mental health, substance use, and behaviors that affect physical health, which are identified during primary care visits. And I think if you guys want to sum up this definition, again, saying that it's a holistic care is way better, in my opinion, than this very long definition. But moving on, we did prepare a slide for you to run you through two different models of integrated care, like to explain better on which one is more integrated. And so as you can see on the left side, we have a biomedical model. So what a biomedical model, I'm sure you guys are familiar with it. It is a scientific measure of health and regards the disease as a breakdown due to some sort of biological reason. So we have a person at the top here who complains of stomach pain and comes to the PCP's office, and obviously, they'll check the vitals when the patient comes in. They'll check their weight, their height, their blood pressure. And once you do see the PCP, the doctor asks you about lifestyle factors. They also ask you about biological factors like family history, or if you have any personal health history that they should be aware of. And then after listening to all your symptoms, they move you to a physical diagnosis. And this is where they conduct routine and standard examinations. Either if it's a blood work that you need, they'll send you to get that. If you need to have a breath test done, you might need that. So let's say the stomach pain is actually an ulcer. The doctor will then send you home with either a medication to suppress your symptoms, or they'll send you home with some sort of antibiotic to treat the symptom. But if we move to the right side of the slide, it is a biopsychosocial model, right? So this diagnosis, or in this model, the considerations are based on biological factors, psychological factors, and social factors. So just like the biomedical model, the doctor does ask you about any family history or any personal health history, the biological factors, but they also ask you about your social factors. is your social determinants of health, right? Has anything happened to you lately that may have caused any stress to you? Have you had a death in the family? Any accidents? And then they move you into a biopsychosocial diagnosis. And this is where they do the blood work. They also do any mental health workup if they might provide you with some surveys to see where you are in your anxiety, or if you have any stressors that's really impeding your health, right? And then they move you into treatment, which is again the same as the biomedical model, where they give you either some medications to suppress symptoms or to completely eliminate the symptoms through antibiotics. But they also provide you behavioral intervention.
Hello.
This
Hey.
is, was it? So this is also where we have a behavioral health consultant or a mental health provider come in, talk to you at the PCP's office and give you some behavioral interventions. And they'll be like, okay, if you have a lot of stressors in your life, here are some coping strategies that you can utilize. Here are some lifestyle changes that you can make to better your overall holistic health. And honestly, the biggest takeaway again is that our mental health affects our physical health just as much as just physical health alone, right? It has way more impact. Like our body responds to what's going on in our head. And I hope that this model gives you some sort of visualization as to what integrated care is. And again, biopsychosocial model is what we want to achieve in our medical practices. And without further ado, I'll pass it on to Sajina, who's going to talk about key components and models of integrated behavioral health.
Thank you, Elena. Hello, everybody. So now that you know what integrated behavioral health is, I want to talk about the key elements of integrated behavioral health. There are very specific models within integrated behavioral health, which we're going to talk about on our next slide. But before we do that, we need to have a good understanding that no matter the model or the type of integrated care that you want to provide, you have to understand the key elements of integrated behavioral health, because without these elements, you would really be missing a step in access and quality in integrated care. So first off, it should be person-centered team care that is collaborative in nature. So it should not just be a co-located care where you have your behavioral health provider on the same facility. It should be more than that, where the team members are learning to work together in different ways, making decisions collectively while keeping the behavioral, mental, and physical health in mind. It should be population-based care where the care has access to shared records. They're able to look at the quality outcomes and measurements and are able to adjust those measurements so that no one falls through the cracks. Keeping that population-based care in mind, there should be measurement-based treatment to target, and those treatments should be actively changed until the clinical goals are achieved. There should also be evidence-based care, which includes, for example, brief interventions, the psychotherapies, using the CBT skills and coping skills, and just truly engaging the patient in the treatment plan, which would only encourage patients to achieve their health outcome goals. And lastly, not only should your team work together with patients, but your patient also need to experience that one-stop shop where all of their needs are met in one place. And as Alina mentioned, our mind is not separate from our body. And so this is where they need to, have access to both services in one place. Next slide, please. So now we're going to talk about the two specific models within integrated behavioral health. One is known as the primary care behavioral health model, also known as the IBH, and the other is called the collaborative care model, also known as COCM. So in this Venn diagram, you're going to see some similarities and differences between those two models. So if you look at the collaborative care model, it includes a behavioral healthcare manager as part of their team. They are generally supported by a psych consultant for complex patient cases. This model requires a patient registry for patient tracking, follow-up, and monitoring. And it's considered a longer-term care where the patients who are enrolled in COCM services, they usually receive service for 3 to 12 months range. And then when we go to the PCBH model, it includes a behavioral health consultant as part of their team. And there's more real-time availability for a warm handoff where the behavioral health consultant They focus on brief interventions that are customized for a primary care setting. And typically PCBH is a short-term care, which can last up to 4 to 6 follow-up sessions. So this is a brief overview of their differences, but as you can see on the screen, they also share some commonalities, and they include that both of them are cost saving. They both focus on team-based care. They both have behavioral health provider as part of their team, and they focus on evidence-based screening. So again, this is just a very quick overview of these two models. We're going to do more. We actually have set up separate trainings for these two models. And if you want to learn more about them, please sign up for it. We're going to do a deeper dive on both of those models in that training. So with that, let's move on to the next slide.
We have a question from Maria
Yes.
Chuli.
Thank you. Just a quick question, if you wouldn't mind going back one slide. I'm familiar with the collaborative care model, so they have the specific billing codes. Are there specific billing codes for the PCBH model as well?
Yes, there
Okay.
is.
And in both of these models, does the primary care physician, basically they're the quarterback of the behavioral health treatment? Okay, so it sounds like the biggest difference between these two then is the short-term versus long-term. Am I understanding that correctly?
Correct.
Okay,
Yep.
I won't say much more, but I just want to comment, and I see that F. Jacobs commented as well, but I'm running into issues with getting some buy-in from the primary care physicians to be the primary billers, and also the reimbursement rates from Medicaid in particular. So that's just my only comment there, but thank you so much for answering my question.
No problem. Okay, let's move on to the next slide. Thank you, Alina, sorry. So now that we've discussed what integrated behavioral health is, I want to quickly go over what it is not. I feel like there's a lot of misconceptions about what integrated behavioral health believed to be, but there are some that we need to absolutely address. So first off, integrated behavioral health is not a co-located model. Just because you have primary care services and behavioral health services within the same building, down the hall, or in a separate floor, that does not make your system integrated. In order to deliver that one-stop shop to your patient, you need to have your behavioral health services integrated into your primary care team. So this is where the primary care team and your behavioral health provider, they are counted a member of the primary care team. They're working together collaboratively from the same office space. It is also not about consolidating separate funding for physical health and behavioral health care. Just because you now have a built-in revenue for behavioral health service does not mean your system is integrated. It is also not about putting physical health and behavioral health services under the line of same authority. Integrated care is not a one-person job. You cannot assign one person to do all things related to integrated care and hope for the best. It has to be a team effort. Everybody working together, having shared goals, building mutual trust, clarifying roles and workflow, and just having strong communication. That's the key. So none of what you see on the screen right here is sufficient enough to really produce that meaningful integrated services. Next slide, please. So now that I've covered what integrated behavioral health is not, I want to do a quick run through of the levels of integration. Here we are with our levels 1 through 6. This was put together by Sancha Harsha for Integrated Health Solutions. So as you can see in level 1 and 2, when we talk about proximity, they are separate facilities, separate system, communicate rarely or as needed, as provider need or as patient need, and they may never meet or meet at a larger community. Then when we move on to level 3 and 4, proximity-wise, they are the same facility but separate space. System-wise, they could be separate or some shared. They communicate regularly by phone or email, or regularly in person as needed, and they meet occasionally to discuss cases or meet regularly on some of the patients. Lastly, then when we look at level 5 and 6, proximity-wise, they have some shared space or they share all space. Their system is partially integrated or fully integrated. They communicate frequently in person or consistently as individuals and team. They provide care as a team. Staff do patient caseload together and have regular team meetings or have team meetings about systems and the patients. So these are the levels, and now these levels are actually categorized, divided in three categories, and this is the scale that was put together by Institute for Integrated Health Solutions as well. So let's talk about each of them individually. So there's level 1 and 2, which is coordinated care. And here we're going to discuss patients and exchange information. We may collaborate at a distance if that happens at all. It's the most traditional way we as patient access care. You go to one place for your primary care provider, and then you go to a completely separate space to see your separate location to see your behavioral health provider. Generally, the primary care provider is working with patient to address physical health conditions like diabetes, stomach pain, high blood pressure, and then the same patient will have to drive far across town, possibly to a different county, to see a behavioral health provider because they may have some behavioral health concerns as well, such as depression, anxiety, insomnia, and so on. So this is the standard way we see care right now for the majority of our population. And then when we get to the co-location model, this is where the providers are sharing some facility space and have behavioral health provider on staff. They may share some scheduling staff and scheduling software. It means that as a patient, you come into the same office. When you walk in, you check in at the same place. Today, we may have a visit with the primary care provider, and in 2 weeks, we may have a visit with the behavioral health provider. And both providers are also aware that there are patients on both ends, and they may even occasionally discuss the care for this patient. But again, they are separate facilities. We have primary care provider just focusing on the physical health conditions, and behavioral health provider just taking care of the behavioral health conditions. So there's really no, not so much of collaboration and really working as a team. And then when you go to level, integrated level, we are talking about really transforming your practice, and you're truly merging the teams together to work together in one shared space, patients, and outcomes. So when we start talking about integration, we put these two providers together, and they are working together with the patient to improve their health and their health outcomes. And that's really a fuller transformation, a merging of the practices and really improving care at level 5 and 6. So that's the level of integration. And I want to go back to the previous, this slide, and want to do a quick exercise with you all. If you could all open up your chat box and identify what level you think you are at on each of these columns. So let's start with proximity. Where do you think your organization is at in terms of facilities? Are you the same facility, separate, shared space? So just put down a number for me, please. I'm seeing a lot of 4s. So that's same facility, but separate space. Wow, a lot of 4s. Okay, I see some 5 now. Some 3, 4. Okay, so I think the max is, so majority of you are saying either 4 and 5. So some of you have same facility, but separate space. Some of you have some shared space. Okay, perfect. Thank you so much. And now let's move on to the system. Go back to the table, one more. Yeah. Now let's do the same thing for this system. Can you put down a number where you think you're at in terms of your system integration? Four. I see a lot of 4s and 5s. So partially in, some shared, okay, and partially integrated. Okay, what about communication? How often are you communicating with your either primary care provider or your behavioral health provider? How regularly are you collaborating with them? 4, regularly in person as needed. Oh, wow, we have some 6 as well. Consistently as individuals and team. We have some too, periodically as patient needs. Perfect. And then finally, let's do meetings. How regularly are you meeting with your provider? At what level do you see yourself? Some 3s and 2s and 4. 3s, occasionally to discuss cases. 5. So our range today has been between 1 through 5, which is really good. Some of you are at the early stages of integration and some of you are really deep in. So thank you all so much for participating in this activity. I'm going to now pass it over to Alina, and she's going to talk about the lexicon for integrated behavioral health.
Thank you, Sajina. So I feel like since everyone scored such high numbers for the level of integration, I just feel like you guys already know this stuff. But for those of you who are investigating and exploring what this is, I want to talk to you guys a little bit about the lexicon of integrated behavioral health. So what is it and why do we use it? So lexicon can refer to a set of terms used in a particular profession, subject, or style. So in other words, it is a shared language of words or phrases that make sense together in a particular setting, right? So if you're someone who goes to the gym and you may or may not have heard these terms, right? So if you hear the word reps, that stands for repetition. And for someone who is in the who's familiar with the fitness industry, they'll know what reps stand for. It's like one set of 3 reps or something like that. It just, in my head, I don't go to the gym that often, so I wouldn't be able to give you a perfect example. But then there's also other terms that you use at the gym that are like bulking or cutting, counting calories, cardio, resistance training. And so if you bring these terms into a clinical setting or a hospital setting, it just doesn't fit there, right? If you use the word cutting in a clinical setting, it can go wrong in many ways. And so for those same reasons, when you're in a clinical setting and you are practicing integrated care, it is so important for us to have a shared language so that we can ensure that everybody is on the same page. And in the next slide, I will actually talk about how a shared lexicon benefits us, right? So it's not just one person or one group, as Sajina mentioned earlier, that a shared lexicon or integrated care affects, right? It's the whole of people that are affected by the system. So that can be the leadership, that can be the clinicians, that can be the patients themselves. So on here, we put the health plans too get affected and benefit from a shared lexicon. So does policymakers and business models. So how does it affect clinicians and medical groups? And I think when we did the poll earlier, majority of you guys are from a clinical background. And so you all know that you guys are the people that live, breathe, and practice integrated care. You guys are the ones that do everything to implement a integrated care and provide the best care for their patients, right? So you guys need to be able to communicate and be able to talk to each other and be like, hey, can we have a BHC come in, or can we have a warm handoff? You guys need to be able to communicate that with each other in order to ensure that you are achieving that integration, the highest level of integration. Right. And if the team isn't on the same page, this whole process is going to be done in vain. And then same thing, like for patients and families, they need to be able to be familiar with some of the languages around integrated behavioral health. Why? Because they should be aware of what to expect and what they could receive from integrated care. They should be able to know, like, hey, we'll have a BHC come in and talk to you. That they should have some knowledge around what the clinic is doing for them and how they're doing it for them. As for health plans, it's kind of like the quote, what specifically do I require clinic systems to provide to health plan members, right? So as health plans, they need to be able to understand what the clinic is providing and how it functions for them to determine if integrated care or the services provided in integrated care is something that they want to invest in and that they want to cover for their health plan members. And I think most importantly, policymakers and business models need to know these languages and understand them when it's put together, because if they're being asked to change the rules or the business model or even advocate for integrated care, what functions need to be supported? They need to know what they're investing in, they need to know what they're spending their time on, and they need to be able to explain the benefits of integrated care and how it affects the population. Right. So as you can see, like a shared language and being certain that you know the language around integrated care is so important, not just even if you're just exploring integrate what this is, but also to optimize your learning experience, right? You're here for this training to learn more about integrated care. And as we move through more trainings in the next couple of weeks, we'll be referring to these terms often so that so we want to make sure you understand and completely understand and comprehend what we're saying and sharing with you. And so these are some of the generic terms. It's not all of them, but it is some common terms that I thought that we can share with you. So majority of you guys might be familiar with what warm handouts are, what patient-centered care is, scheduled visits, team meetings, team huddles, PCP prep, what a cold consult is, co-located care, group visits, coordinated care, and even a meet and greet. So we won't be covering all of these terms in this presentation today, but we have prepared a toolkit for you where we provide definitions of these terms in there. So you guys can use that as a resource to better your learning experience over this topic. And so before I move on to two of the most important terms, I wanted to actually give you guys an activity. So this is, can you guys type in the chat, what is the difference between team meetings and team huddles? And you can give yourself like 3 to 4 seconds before you hit enter. I'll actually let you know because I have to find my chat. I have no idea where it is. Okay. All right, whenever you guys are ready, go ahead and submit it in the chat. Okay, so Eli responded, team huddle are daily meetings, are daily and meetings are weekly. Cindy said huddle is a daily meeting reviewing needs of patients that are coming in that day. Xavier responded, team meetings are scheduled with topic agenda. Team huddle is spontaneous needs. Thank you guys for being so engaging. This is wonderful. You guys are on point with the responses, actually. I mean, I can't blame y'all. Y'all are almost integrated and all right. So I think we don't have any more responses. I'll move on. So pat yourself on the back because you did, all of y'all, I believe, got it right. So team meetings are designed to engage in shared decision-making and treatment planning, right? So with team meetings, you can't really escape this concept anywhere. You'll see it at offices, you'll see it at clinics, you'll see it at businesses, restaurants, it doesn't matter. Right, so with an IBH or integrated setting, it includes the PCP, it includes BHCs, medical assistants, clinical managers, scheduler, or front desk staff, and the length is 30 to 60 minutes, either once a week or every other week. And the purpose, it includes, like all of y'all mentioned in the chat, to discuss important things, improve processes, a continuation of working towards goals, and maybe, just maybe, depending on your clinic and how it's set up, you guys might discuss some patient caseloads as well that are maybe complicated. And then we have team huddles. Again, team huddles is, I think, by far the most important in integrated care. So it is designed with the purpose of shared responsibilities for patient care conducted during the workday. So again, it includes the same set of people, right? The PCP, the BHC, the medical assistant, the scheduler, the clinic manager. And the length and frequency is however long you want it, but most of the time it's usually 10 to 20 minutes of a standing meeting, once or twice a day, either in the morning or after lunch. And this is to, again, I believe someone said, I think Whitney and everyone said, this is to review the patients that come in that day for the appointments, right? So you want to be able to discuss strategies with all your team members on how to engage these patients according to their struggles and according to their concerns and needs. And you can also use this time to discuss any follow-ups that are needed or any tasks from yesterday or the previous day that you might need to discuss in regards to a patient. And again, it's like the whole point is integrated care, and it's the patient-centered care overall. And team huddles, I think by far are the most important aspect of this, or one of the most important things. There's so many important things to this, but and so without further ado, I'll give it to Sajina as to why we should do integrated care.
Thanks, Alina. So now that we've discussed in a good amount what integrated behavioral health is, the lexicon, let's segue into why we should do it. And let's go to the next slide, please. And as you can see from the data here, there is a higher prevalence of depression among the varieties of physical health conditions. So when we look at the data, high rate of depression on those diagnosed with advanced cancer. That seems obvious to us, right? But if we look at conditions like diabetes, asthma, COPD, even for those, these are very common co-occurring conditions with depression. You can see that there's a clear association between depression and chronic health conditions, physical health conditions. And this could be the result of either depression causing the chronic disease as a result or side effect of the medication that they're taking, or the other way around, where the chronic health condition is actually intensifying the symptom of depression. And similar can be said about other behavioral health disorders. Let's go to the next slide. And as you can see on this graph here, the blue bar, that represents those who are diagnosed with severe mental illness, and yellow represents those who are not diagnosed with severe mental illness. And we can see from the data here that people who are diagnosed with severe mental illness, they have high rates of chronic disease than those without. It shows that there's definitely correlation between behavioral health and physical health conditions. It implies that one can certainly influence the other. So the benefit of integrated behavioral health is that it provides resources and tools that are needed to address, monitor, and treat both behavioral health and physical health conditions in the primary care setting. As data implies that there's a need to address both aspects in order to treat the patient as a whole, because again, I feel like this has been my slogan today, but our mind is not separate from our body. Let's go to the next slide. And I know money is a big factor when you're thinking about implementing a change in healthcare system. So here's a report. This was completed for APA in 2017 using healthcare cost and utilization data to basically project spending estimates for patients who have chronic physical and behavioral health conditions. So just to give you an idea, the medical costs for patient with chronic health condition and behavioral health condition are 2 to 3 times higher compared to those without mental or chronic health conditions. So according to this report, they projected minimum, and I really want to emphasize the word minimum here. They projected a minimum of $37.6 billion that can be saved annually by integrating healthcare at a national level. So there's definitely a lot of potential for cost saving. And it just goes to show that the country as a whole can really benefit from adapting integrated healthcare. And let's go to the next slide. And those who have been actually trying to integrate, and I know some of you are already in the process, you know your fair share of barriers that exist to integrating your system. I mean, first off, we've listed here some of all of the many that exist out there, but first there was this mind-body dualism, a declaration that our mind and body are made from two separate substances, so it cannot be studied with the same tools, as they two belong to two separate realms. And then there's that ongoing stigma, of course, with individuals who are having behavioral health and mental health issues. And then there's a systemic barrier, which includes the three: the lack of support and endorsement from your senior leadership, which is key for trying to integrate system. Another big barrier has been the lack of funding. And lastly, lack of competent hiring. In order to provide integrated services, you need to have the right staff on board. Just your primary care provider is not going to be enough to provide integrated services. You need to have a behavioral health provider as part of your team, with both of them having clear understanding of what their role is, their responsibilities, but at the same time sharing equal responsibility of providing quality care to their patients. And while these barriers, they do exist, and we all know changing and transforming your practice, your system, it's very challenging. But even though these barriers exist, I want to share with you all these three organizations that are listed here on this slide who have successfully integrated behavioral health in primary care. So some of the commonalities among these organizations include prioritizing vulnerable underserved vulnerable populations, increasing community collaboration, ensuring strong leadership early in the process, implementing a team-based approach, including the patient as an active participant, diversifying funding sources, and implementing data-driven practices. This is obviously not an extensive list, but I just wanted to share this with you to ignite some hope and encouragement that this can be done. And there are some, studies that have been done that shows that it can work. So now that we have discussed all aspects of integrated behavioral health, we've talked about what integrated behavioral health is, their elements, the two models, the different models of integration, and the barriers and the success stories. I now want to shift your attention to the framework. It's the new framework for system integration, which was introduced to us last year. The Comprehensive Health Institute Integration, also known as IHCI framework, was developed by the group within the Institute of National Council. They put together an expert panel, which included payers, policymakers. They had stakeholders from American Psychiatry Association, American Psychology Association, SAMHSA, HRSA, CFHA, and many other stakeholders were involved in creating this new framework. So it has definitely been a collaborative effort to promote the advance of integration in a more comprehensive way across the nation. So you might all be thinking, why the new framework now? Why can we not, work with what's already built in? Well, there are many reasons, but here, these three are the most common ones. Many healthcare organizations have not attempted to implement any of the current models. There's been many studies that have been done on those models. We have good research out there now, but still, they've not been widely used, and they've not been used as an overall standard in the field. Or they are often implemented as an isolated special pilot project or pilot service instead of a whole organization transformation. Or you're unable to sustain or expand beyond the initial grant funding, even if the implementation was successful, but you were not able to really keep going because the initial grant ran out, therefore the program ran away. So why are we in this situation? I mean, even after the decades, we're still not able to really commit and successfully implement integrated healthcare. We started off with, 4-quadrant model. We have the 3 levels of integration, the SAMHSA's 6th level of integration, which I covered earlier today, and that's the most prominent right now in the field. And looking at all these existing models, we have research on what is best practice, what makes collaborative care model work, what makes PCBH model works. There's been research happening. There's evidence that shows improved clinical outcome. But in spite of all that, there's still this barrier that exists, such as lack of flexibility in implementation, we're saying that if you do not do every components of the model that you're trying to integrate, then you're not really integrated. So maybe there's a need for more incremental, broader approach. It has also been difficult convincing our payers, either at government or managed care. They like the idea and are willing to pay for integrated care, but we're not able to really show the value on how integration is really improving performance measures. And because of that, we really don't have a way to connect our integrated care to true value. And our payers, they really want to see the value. They want to find integrated care programs that actually demonstrate people getting better, but this can fall short if you do not have outcome measures. And because the payers and policymakers really want to see value, and because we're not able to demonstrate that value, therefore we don't have the financial support, right? So this is where the new framework comes in. Let's go to the next slide, Alina. So this new framework, it's designed to address all of those barriers. This framework, it really emphasizes on the bi-directional integration that is critical, and that we really need to prioritize patient-centered care. So we need to bring integration to where the patient is. Therefore, it covers both physical health and behavioral health. If you're in a behavioral health setting, you need to pay attention to the physical health needs. And if you're in a primary care setting, you need to pay attention to the behavioral health need of the patient in order to provide that patient-centered care. This framework is designed to advance integration for providers, for payers, for population managers. Particularly, it provides guidance on how to measure progress in advancing integration as you're moving from the earlier stages of integration to more advanced form of integration. It also allows you to demonstrate value that your organization has produced as you are advancing in your integration. It also provides guidance and recommendations on the funding mechanism that are appropriate for both initiating the integration and sustaining it. So it really covers the barriers that we're facing right now at this stage. So with that, let's move on to the components. So here are the key components of the CHI framework. There are evidence-based 8 domains, which are your care processes that address both physical health and behavioral health. It's designed for integrating behavioral health into primary care or primary care into behavioral health. It gives you a list of exactly the tasks that you need to be doing, but of course with some flexibility. And then we have the 3 constructs. They are called integration constructs, and all these domains are actually measured under these 3 constructs. And if I could put it in simpler terms for you, think of it as the 3 buckets that you could be in. So either you're at the beginner bucket, intermediate, or advanced. You're able to do a self-assessment throughout those 8 domains and see which bucket you really fall in. And so there's flexibility here. It's not as rigid as the SAMHSA 6 level that we saw earlier. And then we have integration metrics, which will allow you to connect your progress to the metrics. And then lastly, we have integration payment methods. So those are the key components of the framework. I just wanted to introduce this to you all today as a placeholder for you to know what's coming up on our next training, which is scheduled for in 2 weeks, in I think April 12th, if I'm not wrong. Anyway, we're going to provide you with the registration link for that, but that's where we're really going to do a deeper dive of this new framework. We're going to try and cover as many domains as possible. There are 8 of them, so we may not be able to cover all of them, but that training will be dedicated just on this framework. So if you want to learn more, feel free to join us. So with that, I'm going to pass it over to Alina, and she's going to show you the 8 domains and the constructs.
Thank you. Okay, so as Sajina mentioned, these are I'm struggling with technical difficulties, guys. Okay, so these are the 8 domains of the healthcare integration. So these are evidence-based domains from the CHI framework, which are your care processes related, specifically to addressing physical health and behavioral health issues in an integrated manner. And again, as Sujina mentioned, this slide and the next one will be just a brief snippet of what is to come. And I believe there is 8 domains, but they're all very content heavy, but very important. All of them are still very important. And the 8 domains leads to the 3 integration constructs, where the domains, they use these constructs to track their progress. So compared to the previous framework, we no longer use the terms levels anymore, but we use the word constructs because each of these components, they build on each other, right? Like you cannot get to comprehensive treatment and population management without completing or achieving or getting to screening and enhanced referral, as well as care management with consultation. And again, we'll talk more about it if you guys are curious. We are providing you with some resources in the toolkit if you can't wait until the next presentation. But please do come back for our second part 2 to intro to IBH so we can further go into depth on these factors. And these are the references that we used. And the 4th one is the new framework link that you guys can go to, and is also again in the toolkit. And before you go, we are approaching the end of our presentation, and we do have an activity for you, and it is to open the chat box and let us know, based on the information, complete the sentence. So based on the information I learned today, a question that is emerging for me is, and yeah, I'll give you guys a few, or there's another one, a bold idea I can recommend at my organization is. So feel free to complete either of these sentences based on everything that you've learned today. Maybe it's something you already knew, or maybe it's something you didn't know. So let us know. And Maria responded, how do we show value to our payers as far as positive outcomes of IHCI so that we can secure better funding? Then we have what kind of support we have from the state to encourage this idea. How can I integrate with all providers? What are the specific behavioral health quality metrics that I can be looking into to ensure ongoing funding? I think, Sujina, this is in your lane if you have an answer to Whitney's question.
So let's do this. These are all very good questions. And when it comes to metrics, that's exactly where I am focusing my learning for next week, because this was just introduced to us last year and we're learning with you all. So definitely join us next week to learn more about this. These are great statements.
Yeah, really wonderful questions. We will take a note of it and see if we can address them in our next presentation before we even get started. These are great.
And for those who are trying to get some buy-in from either your coworker and also from your leaders, I think lead them towards some of the trainings that are available for integrated behavioral health. I think first thing that they can really do is learn about what this is, and then the next step would be to really have that conversation and see where to go from there. But feel free to have them join our trainings. There are so many different resources that are available, but the very first step would be to educate ourselves on what are the benefits, what it entails, and if you guys have the bandwidth to do this transformation.
Yeah. And thank you, Sujina. Oh my goodness. Okay.
So
And so We
Go ahead.
have a survey actually prepared for you guys. So tell us how we did. We actually would like to know your feedback. Do you want us to include more information? Did we not talk enough about something? Tell us how we did and scan the QR code now.
The codes. We actually have a training scheduled on fee for service, and that will actually focus on the codes for primary care behavioral health model and for collaborative care model. So yeah, feel free to join those trainings. I think those will be really informative for you to learn about the code questions.
Thank you. And just to clarify,
Mhm.
that training, does it address kind of some of that, like, as I mentioned, administrative challenges that I think PCPs might encounter with this model? Because basically, quickly, my organization, our goal is to get behavioral health integrated. So I'm trying to talk about collaborative care and things like that. And this is something that comes up frequently from the PCPs, which is I'm the one PCP collecting the doing the billing, collecting the co-pays, paying the invoices, and it's kind of an administrative burden. So how can we potentially lessen that or sell that for our PCPs?
Right. Yeah, definitely. All of those will be addressed in that training. So feel free to join us.
Thank you.
Mhm. Well, thank you all so much for joining today. This went by quickly than I had expected, but if you have any further questions, feel free to reach out to us via email. Victoria is going to follow up with the survey link. Feel free to include your questions in those surveys if you have any. And yeah, thank you all for joining. We hope to see you all in 2 weeks for our another training.